ค่ะขอต้อนรับทุกท่านกลับมานะคะในช่วงเสวนานี้นะคะก็จะประมาณ50นาทีนะคะดิฉันคิดว่าถ้าท่านไหนมีคำถามคำตอบในช่วงท้ายก็สามารถถามได้เลยนะคะแล้ววันนี้นะคะเราได้รับเกียรติจากท่านวิทยากรนะคะทั้ง4ท่านด้วยกันนะคะเมื่อวานท่านพบแล้วกับอาจารย์เยาวนุชนะคะผู้ช่วยศาสตราจารย์แพทย์หญิงเยาวนุชคงด่านนะคะกรรมการผู้จัดการบริษัท RFS นะคะ Mr.SK นะคะจากที่ได้เจอเราเมื่อตอนเช้านะคะผู้เชี่ยวชาญด้านระบบคุณภาพนะคะมิสเตอร์เอริกนะคะจาก ECRI ที่ได้มาอยู่กับเราเมื่อเช้าแล้วเช่นกันนะคะแล้วในโอกาสนี้เราได้มีโอกาสต้อนรับมิสเตอร์พอลนะคะคุณพอลเป็น infection control expert จากประเทศอังกฤษนะคะคุณพอลมีประสบการณ์มากว่า30ปีในด้านระบบสุขภาพในประเทศอังกฤษนะคะปัจจุบันคุณพอลดูแลบริษัททางด้าน healthcare related technology 4 บริษัทแล้วก็เป็นผู้มีส่วนสำคัญในการสร้างมาตรฐานระบบสิ่งสนับสนุนในโรงพยาบาลให้กับมาตรฐานของประเทศอังกฤษนะคะแล้วก็เป็นผู้ตรวจประเมินโรงพยาบาลชั้นนำในประเทศอังกฤษนะคะซึ่งคุณพอลจะอยู่กับเราในช่วงนี้แล้วก็ในช่วงบ่ายคุณพอลก็จะมีเซสชั่นในเรื่องของ hygiene ด้วยนะคะ so thank you very much for your coming today and for these sessions. Yesterday the seminar we discussed a lot about our practice in healthcare facility management in Thailand and we talk about the approach to improve the healthcare facility management including the technology, biomedical engineering, also the environmental things. And I'm sure that today everyone would love to know more about the international practice and how can we improve or what is the journey to go to that international level and your perspective on how to manage the facility management. So I would like to start questions in the areas of clinical engineer or the medical device management. Mr. Erik, as ECRI has one of the key roles to promote good practice in medical device management. You have seen different practice in many countries, including Asia, and of course, I would like to know about your key observations of the current practice in Asia and how can we improve or compare with others in Asia and international. Please.
Thank you. That's a very good question. There is actually, based on observation, there is actually a couple of categories that we see in Asia right now. There are countries that has evolved in having biomedical engineering to play a very critical role in supporting the rest of the hospital team in managing the technology that they have. There are still countries who are struggling to actually find a way to manage the technology. So if I may, we have two different quadrants, and it's again a journey to move on. And biomedical engineer or engineering facility in the hospital in the Western world, especially in America, is getting very important to the management of technology. Why? Because technology are driven by a lot of technology advancements from engineering's perspective. And a lot of times that clinical experts like doctors, clinicians, nurse, they are the experts in using the equipment and the devices for the patient. But engineers are the expert in the technology itself. They know what to do with the technology when there is an issue with the technology itself. So the combination of support between the parties, different relevant groups, are becoming very relevant in the West. So that seems to be some key observation I see from the Western world. And in the Eastern world, which is in Asia, developing countries are starting to recognize the importance to manage the technology itself. Many ways they do. They involve processes, they involve the development of expertise in technology management, such as the engineers and the ITs. They involve the adoption of technologies. How do hospitals adopt new technologies? In the Western world today, they are involving various experts in technologies, including the engineers and the ITs, on top together with the doctors, to look at what sort of technologies are good and viable to adopt, so that when they adopt, there is already a congruent approach to how technology is being managed in the hospital itself. So far in Asia, we are playing catch up. We're getting there. The struggle in Asia is again, we do not have enough people to manage the technology. We may, in some countries, do not even have enough users like doctors to be available to use those technology as well. So there are huge differences between the regions in Asia itself, but I can see that there is a good movement towards this particular journey, and a lot of the Asian countries are moving towards that. And the awareness of having patients being very safe in a hospital is becoming something very important to those facilities. Yeah.
Okay. Thank you very much, Mr. Erik. So the emphasis of the adequate people with the right competency, like technology man or engineering man in the hospital, is become more crucial. You mentioned about difference in Asians. Actually, in one country, there's also difference between different scale of hospitals. Like in Thailand, the large scale hospital or the large private hospital that have something similar to what you mentioned in the West, but for some hospital in the skirts area, we found very limited resources for even the clinicians, as you mentioned. So to move on with this one, yesterday we discussed about for many hospitals, the tendencies of managing the medical devices on the outsourcing. Right. So we try to outsource this expertise to those professional provider, and also there's some questions like that. So if we outsource, what knowledge or capabilities as a hospital need to know to manage the outsource?
Very good question. Thank you. And I think from the hospital point of view, where I used to manage the hospital, we also outsource our engineering services to a third party in Malaysia. And what we need was that we need to know what technology we have as a management of the hospital, and what are the kind of outsource we want to outsource to the third party. The important thing is to have a committee in your hospital that does a periodical assessment. I have a committee team last time where we sit on every 6 months to review with these outsourcing services company on their KPIs and performance. Of course, the key thing is about managing the technology. How much have they done to manage those technologies? And not only we want to know what are the good things that they found when they are managing our technology with us, we also want to know what are the bad things that they find. So we try and get as much as a neutral or an evidence facts, so that we can make correct decisions to what to do. So having an outsourced party sometimes do help, and I don't have to have the issue of thinking about what we need to put together to maintain our equipment and technology. In the hospitals we have, I think my hospital has about 3,000 over devices, the last count. And the devices is so many, it's very difficult for people like us to keep. We tried to do it ourselves before, but we don't have enough engineers to go around and support that part. So to ensure that we successfully run our technology efficiently and consistently have the equipment going on positive, we have that outsourced. And in different countries there is different challenges. Yeah, so it's up to the situation that you have. Yeah.
Thank you. So at least you need to have groups of experts or committees to look the policies of how do we outsource this practice as well. And those for many private hospitals in Thailand so capable of outsourcing this kind of thing. But there are still some hospitals, I'm sure that not only in Thailand, in the skirts area, but also in many countries in Asia, the limited of resources cannot, allow them to outsource such quite an expensive, contract for medical management, medical device management. So what could be the very simple step for the hospital themselves, minimal things that they need to do in order to manage the medical device effectively?
Okay, I see this a lot in the South Asia countries. Indonesia, Thailand, some part of Malaysia still happens, not many, but Thailand, Indonesia seems to be very prevalent. If you have a situation where budget is very tight and you may only have one technical guy in your hospital and you do not have enough funds to outsource for people, then you have to manage your technology. So as a management of the hospital, you got to understand what technology you should adopt, what are services you can provide and you cannot provide. Let's face it, we only have limited budget. So if you only have that many limited budget, as much as you want to help your patient and providing different services in your hospital for patient, we got to be relatively effective to see what you can do and what you cannot. So manage your technology. Do not offer to treat cancer in a small hospital who has less budget. How do you treat cancer when you do not have the technology to support it? Do not do neurosurgery cases in small hospitals when you don't have enough budget, because you need an extensive ICU and a lot of manpower, and you need the expertise of the neurosurgeon to be there to follow up on the patient as well. So if you have a community hospital, which is a smaller size hospital with little budget, manage the technology and the type of service that you want to offer for your patients. And from deciding on what sort of services you have, you will be able to plan for the technology you want to adopt. And with that, then you can manage with very little what kind of services and maintenance that you could adopt in terms of the policy to maintain the consistency of those technology within your hospital. So I think that's a start. Of course, then what is adequate? Will the technical guy be adequate or not? I think no matter how budget constrained we are, like doctors, if you are not trained well to do a surgery, then you will have problem. Then your engineers are the same. If they are not trained well to do something like that, they are not going to be able to fix and maintain your equipment effectively. So when there is an issue with the equipment maintenance and management of those technology, then it will cause issue to your patient eventually. So for simple cases like maybe appendixectomy, if you have something that doesn't work well, like a diatomy, the bleed will continue to bleed and you will not be able to stop, then you will have an issue. What do you do? So you will create an adverse event for the hospital itself, just for a simple case that you have to do. So giving them enough knowledge, training in one way or another is very important to maintain the technology. So we're Asians, right? So with little resources we have, we make do with what we can. Usually that's what we are. But so manage the technology, manage the services you want to provide for your patient. That's my take.
Thank you very much. So first the truth, what you can afford to do, and then focus on it, and don't forget to develop the technicians people, even though you have a limited budget. Okay. So next question is about the hospitalities management. When we talk about the cleansing, the environmental, the waste management, it seems to be a very simple jobs. But when we talk about the hospital environment, this becomes more crucial, especially for patient hygiene and safety. We have Mr. Paul here. Mr. Paul, could you share with us Mr. Paul will share with us a very interesting topic on hygiene this afternoon, but before that, could you share on what's the key area of the environmental management in healthcare service, and why do we need to clean? That's the key questions. Yeah.
Good morning. If you don't mind, I'll do this in English rather than Thai. I've been in government for a long time, so I rarely ever answer the question I'm asked directly. And I'd just like to make it, if I may, just an add to my UK perspective of your observation there. In the UK, after 1999, there was a massive push to contract out services. And to make a very long story short, currently 68% of laundry services are contracted out, 53% of cleaning services are contracted out, 42% of food services are contracted out. And that ran for about 10 years until we had a process whereby the ownership of hospitals, the funding of new hospitals changed. And with that went this notion of total facilities management, which I know that there's a lot of people who have an interest in that here. And we now have something like 50% of our new hospitals. And since 2000, we've built 79 new hospitals in 10 years. And all of those hospitals have total facilities management contracted out. So in terms of numbers, where have we been, where are we going? That's certainly the UK and increasingly the European services. So that's on the non-clinical side. Certainly when I ran some fairly big hospitals, on the clinical side, I felt was what I was paid to manage. I didn't have time, in all honesty. If I've got 1,300 or 2,000 beds, 3,000 beds to manage, I don't have time to worry about things other than clinical services, in all honesty. And increasingly, as budgets become tight, and I'll talk about this a bit later after the banking crash of 2008, and quality issues and safety issues particularly, my ability to deal with non-clinical issues became much more constrained. And therefore I'm a bit of a believer in dealing with the things that I must deal with. And for example, in London, which has a population of 25 million people, in Greater London, we formerly had, until 3 years ago, 28 hospitals that were on take for stroke services. 28. And more than half of them were poorly staffed clinically, 24/7. And our performance was very, very poor. In the last 3 years, we've rationalised that. There are now 8 centres which are highly staffed, highly trained, and my ability to get a stroke service within 8 minutes is now on the ball. And I think that's a really good example about, if you've got to get things, rationalised, then be bold, be brave, and get on with it, because it does work. So, sorry, that was just an addition to what you were saying there. So, back to cleaning. I'm going to deal with the technology a bit later, as you know, but I wanted to just talk 2 minutes about my sense of cleaning. My mother believes that if she goes into a hospital and it's clean, it looks clean, then the infection rate will be low. That's what she believes. Now, I can't do anything about that. I've talked to my mother at great length to try and tell her, maybe that isn't the case. Maybe it is the case. Maybe it isn't the case. I don't know. So that's the sort of background here. I want to share with you the UK experiences around this notion of cleaning. If I get this bit right, we'll be fine. This one? Thank you. Okay, so there's roughly speaking what I'm going to do in about 4 minutes, I think. So we'll press straight on. So, is it an art or is it a science? We have this endless debate in Europe about whether cleaning is an art or a science. The trouble for me is that there isn't any evidence base for cleaning. And I've looked around the world, I've worked in America and I've worked in Europe, and I can't find it. I know some things, but I don't know much more than I really ought to. So, I don't know. Is my mother right or is my mother wrong? Who can say? However, what I do know is that, there are bugs and they live in the environment. Now, bugs, as we know, don't have wings, they don't fly, they move around on dust and skin, particles and the like. So they've got to move somehow. They don't have a mind of their own, the bugs. So that's a really important fact which I want to touch on after lunch, which I hopefully will. So they're around, they exist in the environment. We can demonstrate, these are the evidence, that to get a bug from here to there, we can pretty much understand how that happens. However, if I take a swab from underneath patient A here and type it, and then I go and look up here, 6 times out of 10, the type of this bug will not be the bug of the patient in that bed. It's Very interesting. But I will find the bug of the patient in that bed, one bed up, two bed up, three, or somewhere else in the wall. Now that alone, in terms of the science or art of cleaning, is a fundamental place to start. Because what's my objective other than having a clean, smart-looking hospital, which is absolutely crucial, no question about that. But at a functional level, an infection level, what does it mean? It's very, very complex. So, well, we know how it moves. That, it can move either in the air, on hands, on equipment. It's straightforward. We know, roughly speaking, how it gets about. We don't know how it actually physically moves necessarily. And we've done a lot of work with fish tanks full of water and dye. And if you pump air in here or dye in this end and watch the flow, imagining that these are flows of air through walls, you can put some little beds in the bottom of the fish tank. You can see how things work. Now, if you put a barrier in, just a small barrier, so the flow moves up, does that mean that the patients to the, if you will, the left of the barrier get less infection than those on the right? You simply don't know. You simply don't know. But it's an interesting and I think increasingly important point. And again, in droplet transmission, a lot of people talk about this around the world, and I've yet to be really convinced. There are some things that are important, some diseases that are important in terms of droplets. But, and I'll come back to this later, that the size of the droplet matters, absolutely matters in terms of how far it gets away from its source. So again, a lot of people who take certain precautions may actually be doing themselves more harm than good. So we'll come to that later on. And this is a slide I particularly like, which shows the complexity that here's a few methods of deciding what's clean. There's interesting work, it's quite recent, 2013. So if I look at it, the evidence says that I can get it about 40% right, maybe. If I use a UV marker, I get a bit better outcome in terms of knowing that something's clean. Now, the ATP, which I'm actually a big fan of, doesn't perform terribly well here. And if I culture it, of course, I get the best results. So when I'm looking at cleaning and I'm trying to be scientific about it, how is it that I'm going to do this to get a result that's meaningful? Because if I choose the wrong one, I'm going to have all my cleaning people doing the wrong things at the wrong time and achieving the wrong results. So my sense is we need to be more precise. And again, I'll come to that this afternoon if I may. Here's a couple of examples that in the UK really set us buzzing, I clean the floor, that's fine, absolutely fine, and I can either use disinfectant or not, and it doesn't really matter. But an hour later, I've cleaned the floor, 1 hour later, mostly the contamination levels are back to where they were before. The half-life is very, very short. So, what are your policies in relation to that? Does it matter if I clean the floor once a minute, once an hour, once a day? Why am I doing it? And what am I hoping to achieve? Other than it looking nice. Got it, I understand that bit. But, in terms of value for money, because that's what we're talking about here, isn't it? Value for money. I put money in, I want outcome. I don't just want a pretty hospital. And that's really, really important. And the same thing, we have this vast debate about door handles. That if I use the lavatory and then I wash my hands, quite right. And then I go out and I touch the door handle, and now these days people try and sell us door handles that eject alcohol gel. Great, if you want alcohol gel on your hand going out of the lavatory. Because for some bacteria it's useful. But as soon as I go outside and touch the rail along the corridor or touch something else, that whole process is of no use, of no value whatsoever. So again, all I'm saying here is in terms of are we looking for value for money for our infection control buck, if you will, then I don't know. You may have all this cracked. Certainly in the UK and Europe, we don't have this cracked at all. And I'm going to bring this to an end here. But See, there's a couple of very good examples where it says, what we know for sure is that cleaning gets rid of bugs environmentally. No question. But the question really for us is, does it matter? Does the level of environmental contamination matter in terms of getting MRSA or getting C. difficile? There's no evidence to show that it does. There's lots of evidence that says if I clean this room, my environmental contamination goes down by a great deal. But again, its half-life is very, very short. And so therefore, would I be better to concentrate solely on hand hygiene rather than these other, they're not mystical, but they're unproven. So, in England, this is just, you did all this yesterday, but we have a national standard, and I'm a big believer in national standards. I run hospitals, I know how to run big hospitals, I know how it works. And what I do know is that unless the public, citizens, have an access to my outcomes, then I have a paradigm difference with what I think I should have. I believe that infection rates should be published by hospital nationally. In England, every quarter, every hospital has to report their MRSA and their C. diff results. And these are website based, so every single citizen can go on there and see it. Now also, more importantly from a government point of view, and in 2006 Mr. Blair got this one in his head. He really got HCAIs and sent us out to try and get rid of most of this stuff. And the way I think we probably did it, 50% of our success was down to the fact we had national standards, we had national reporting, and we had public accountability. So no, that's how we did it. So, and I'll show you this afternoon how successful we were. So I think that's enough for me. I don't think the only other thing I really wanted is to, we do measure things. This is a list of 51 things you have to go and measure and swab and test, but you've got all that, you know all that. And I'm very sure that you have also in England, local people go and inspect their local hospital. That was quite interesting. That's obviously something that's emerging. And these teams, I'm just going to backtrack here if I can. As you can't see here because it's too small, but there were 1,300 hospitals were inspected last year by local people. So no matter what the science says, no matter what the management says, no matter what anybody else says, what we do is we have these people go round. Am I going the right way? And then we publish. That I'll come back to. Publish rules. Then I can go on the web and I can see how clean my hospital is, what the infection rates are, and so on and so on and so forth. So I can make a choice about which hospital I go to. The only other thing I want to say here is that, and I'm sure you have this down to a fine art, is I can, on my phone, I can look, if I'm the hospital manager, I can be anywhere in the world and I can see all the standards of cleanliness I have, all the standards of food I have, all the standards of laundry I have, because, we have a database, each hospital puts into it, so it's very, very public, and above all, it's transparent. So that's our view from the United Kingdom.
Thank you very much, and that was something that's really effective. You have the policy, the national standard, and you measure it. Make sure that every hospital present the data according to the standard, and moreover, you let the public visit and rate it and publish it to everybody. So that's a very effective way. Let the population control and monitor the things. Thank you very much. And I'm sure that in the afternoon, as Mr. Paul mentions, you have over an hour with Mr. Paul to talk about the hygiene things. And another thing that hit me is that the measurement and the information, and also Mr. SK mentioned this morning that information is really crucial for quality. You cannot measure things, you cannot improve things. And talking about the quality, it is truly a challenge because we have to change and adopt many different things. For the beginners, for those hospitals that maybe not adopt the full quality systems, how would they start to improve the quality? Thank you.
Thank you very much. Good morning. In the hospital, the facility health care management, I know there are many activities that are going on at the same time. And when we talk about improvement, we start looking at everything and become very overwhelming. That we basically say that there are too much to do and the only way to get out. So, but get out is never the solution. So we have to get through. So Eric mentioned about resources. I think in every hospital there's always a resource constraint. And not just hospital, I know every organization there's always resource constraint. So to start off with improvement in the healthcare facility management, I always go back to the basic. Go back to the basic. As I mentioned earlier, is that first thing is that we need to know what we are doing, our mission and our vision. Then from there, we identify the key operational processes, and because of the limitation of resources, perhaps we want to consider something like the 80-20 rules. Do what we can within our means at this moment, a step at a time. There's a Chinese proverb that says this: a journey of 1,000 miles begins with the first step. So at least we take a step at a time. Because if we start thinking of wanting to do everything, I think the likelihood is that you do nothing. So back to the basic means that at least we identify the key operational processes or those that are directly affecting the patients or their relative as a key areas. Then maybe the simple tool to do is that come up with a process map. See what we are doing today. These are very basic tools that I'm talking about. That chart out the basic process and see whether we are doing it that way. Because I come to understand from many organizations that they always talk about their processes, but when we talk to different people within the same organization, they all have different ideas and never seems to be consistent. So you end up, they talk about one process, but there are many ways of doing it. So there's lots of inconsistency leading to what we call the quality problem. So the very basic tool is that let's come to understand our own key process by mapping out the process and then try to understand where are the limitations, where are the constraints, where are the issues that we are facing. Then identify what are the gaps that we need to improve. And this is what I mean by actually setting measurements. Okay, that the moment you know what you are in the present situation, then we can talk about where we are going, how to improve. So once we have established that, I think for organization or those small little hospital, we still can do improvement. So the challenge is that how can we find the key areas and allocate sufficient resource to deal with that and use the basic tools like as simple as a flow chart to help us to know what is going on. Understanding what is going on, then we can take a step at a time and move from there. Thank you.
Starting with the key area and a very simple tools like flowchart and then focusing on it. And any for more mature hospitals, I think many hospitals or many organizations try to adopt more complicated tools like so what we heard, the lean things or Six Sigma things. So for those who have higher maturity, what would you recommend for go to the further steps of more complicated tools or techniques?
Okay, there are many tools in quality. So what I mentioned, a very basic one, and I think earlier Paul also mentioned about collecting data and doing analysis. These are very useful to understand what is going on within our organization. But earlier I also talked about learning from others. Now let me relate to you one story. There was a CEO in a hospital, we call it the restructured hospital in Singapore. Okay, and he's one person that probably doesn't believe in things like you mentioned Six Sigma, used for improvement. Okay, he said that's only for manufacturing people, those who are producing products, but not the hospital. So for quite a while he doesn't believe in this, but somehow I don't know why. One day he decided to go on the trip together with the Singapore Productivity Board to Japan to learn something about Six Sigma. Okay. As he went through the process of learning what other people are doing, suddenly he realized that Six Sigma is not just for manufacturing, and it is also applicable. It's just a question of how we contextualize those things that other people are doing into our own businesses, in our own operation. Okay, like I mentioned earlier when we talk about benchmarking as well. So looking at the similarity in the operation, in the processes, and how things are being done, why certain indicators are established, then we can learn something from them. And because of this process of learning that he went through, he came back. He revamped the triad process in the hospital. And they make changes and improve the patient satisfaction. So besides using this Six Sigma, of course there are many other tools like I mentioned, benchmarking. Learning from others need not be just doing a formal benchmarking. I think sometimes if you like go on informal basis of exchange ideas, or I think we start establishing database, there are many things that we can work on there to start on improvement.
What you just said remind me for the latest visit to one of the Japan hospital under the Toyota Group hospitals, and we found that they adopted just-in-time concept and Kanban concept in the hospital with very limited investment. I mean, they do not need to use a lot of money, but they adopt the concept and apply it to so it's very similar to what you just mentioned. So to adopt this kind of technology, quality improvement framework or approach, what is the challenge that we will be facing in the future to adopting this kind of things from your experience?
Okay, let me just continue from just now. That is not just learning the tools that we can use for improvement, but I also learned that in every management system or in everything that we do, there are certain principles. And one of the key principles I learned for many years is this thing called PDCA, which I mentioned earlier, plan, do, check, act. So before we embark on something, let's plan and determine what is the end objective that we want to achieve. Okay, having set the end outcomes or the objective, then we look at how can we do it, and we start by charting the activities. Of course, we don't spend our whole life charting and planning, no? Then there's only a paper exercise. But the important thing here, I believe, is commitment. So getting things done. Because over the years, I've learned also that many people are very good in planning. But when it comes to implementation, things don't seem to work, and they abandon things very fast. Because the moment they implement, they find that there are challenges, there are difficulties, and don't do. And then some do it, they find that what they do don't follow what they plan. So then there is the need for learning and verification and making changes as we move along. That's a pretty CA principle. And of course, there are many other principles in the management system. But when we adopt all these principles and all these basic tools to just start on the processes, then we can look at many benefits. Okay? The first thing I think of is actually consistency. Okay? Consistency in doing things. Of course, you can say if we are doing consistently good, surely this is good, right? But if we are doing consistently bad, is it really good?
No.
There's food for thought. But at least it's still consistent, right? But the worst thing is that I think when we start doing things that are inconsistent, that's totally unpredictable, and we don't know what will happen next. But nobody likes that, right? And I suppose when things are unpredictable, it becomes very accident prone, very risk prone. Okay? So at least we start out with consistent. Even if it's consistently bad, I will have the tendency to say that it is good. Why? At least I can identify a pattern,
yeah,
a trend. Then there is a baseline for me to know what to do. Okay? But when it's inconsistent, I go bonkers. Okay? So the first thing I look at is the benefit of consistency. Then I look at, eventually, is the patient satisfaction. Okay? Are the patient happy about what we have put in place to make things easier for them? So, some very basic thing is, sometimes I go to a hospital or some to other places. The first thing I go into the entrance, I lost direction. And if it's an emergency situation, no signboard, nothing, nobody helps me. So I will be panicking all the way. Housekeeping, I think, is something that we need to look at. Okay, so there's a patient satisfaction. Then of course we will have something that is, once we implement something, we get consistency. I say consistently good, then there's consistently bad. Of course, consistently bad is not effective at all. So effectiveness comes in. So we need to set some measurements, and then when we have measurements, we will reap the benefits of where we are doing right and where we are not doing right. Because then at the end of it is that we have some form of standardization. So we know that in the healthcare facility management, most of the jobs are done by people who are less educated. Because even if you talk about Singapore or other countries, most people who are educated don't want to go down to washing the toilets, cleaning. So in that case, if we have standardization, some of these things will be very obvious and very clear that how things are being done, and there will be great benefits. Of course, there will be challenges as well. Okay, there are many challenges. One of the key challenges I came across is, I mentioned earlier, is commitment. Management commitment. They don't have the desire to see things through. They want to do something, but running out of patience very quickly, running out of resources very quickly, so they will give up very quickly. Okay? And another area is teamwork. Teamwork, because different departments has got different priorities. Every department wants their own work done, and other department comes in with their activity that we find that it's not our business at all, so why bother, no? So in that case, there will be a conflict of interest. So teamwork comes in, become a issue. Okay? And of course, there are many companies I went to, they find that quality is never their priority over their day-to-day work. Very interestingly, I talked to some people. Whenever you have problems, where do you go to? Quality manager. Why? Because he's only one with the title quality. You got a complaint, go to who? Complaint manager, but there's no such person. Is there a complaint manager in your company? You probably have a quality manager to take a look after the complaint. Okay? But earlier I saw one slide that Eric put up was interesting. Everybody business. Okay? Quality is everybody's responsibility. We cannot say that it is not mine, so it's somebody else. Okay? Unless we take responsibility for quality, whether it's in the hygiene sector, whether it's in the complaints or medical devices that gone wrong, everybody has got a responsibility to take charge. So I find that one of the challenges that we encounter is that people always think that it's not my problem, somebody else's issue. And of course, finally, it's still lack of resources. They say no money, no talk. So again, it's a question of prioritization. Yeah. Okay, thank you.
Thank
very
you
much.
very much. So I put the word quality in front of the position title for every managers now. So quality became everyone's responsibilities. Okay. So Mr. SK mentions about the key things you have to think about when you implement qualities. Actually, you have to do quality work every day. The very first thing is the consistency. Even if it's consistency not good, at least you know you have to prepare for things. You can predict things, and then efficiencies and customer satisfactions. And come to RFS. I know that RFS is one of the company who try to adopt international practice, any best practice to service our customer at the best level. But adopting such a practice in our environment quite challenging, considering the readiness of many resources, even the cultures. I would like Adan Yawanut to share the challenge and the journey of how can we adopt and adapt the practice to our own environment.
Okay, for the RVS, I will share that the experience in the first year. In the first year, as I tell you that before that, I have zero knowledge about the facility management, and we have the consulting from some Western country to set up. I think it's maybe when we apply the international standard or for the way to manage facility in the hospital without adaptation in our hospital, I think is really have a big problem for us. The first the thing that I have we are so different is the cost, because in the US or in the Western country, when we apply the planning of the budget for the facility, I think it's maybe higher than in Thailand. It's 2 or 3 times. In the first year, our figure number of the money that we set the budget is over for the 2 or 3 times. So I think when we adopt in our country, I think we need to set in the minimum cost that is effective in our hospital. In the university hospital and in the primary or secondary hospital, I think the cost is maybe so different. And the second is for the culture, the behavior of the staff personnel. I think is our Thai people, we have some problem is maybe just for the discipline and for the trust in the interprofessional skill that I mentioned on yesterday, that our doctor, our nurse not believe in another people in the hospital. We believe that we have some ego that doctor can do everything. In the operating theater, surgeon, we know about the environment. In the operating theater, we know about the equipment. The nurse, we know it about the cleaning. Is our belief. I think is old belief. Nowadays, I think the technology is change rapidly until the doctor cannot catch up, nurse cannot catch up that technology. Especially is I'm a surgeon. General surgeon is 10 years ago we can operate everything in the abdomen, in the breast, and nowadays for me I cannot operate something in the abdomen because the knowledge and technology is moved rapidly. As a family facility management, so how can we change doctor, how we change the clinical expert to believe in the other professional? I think the first step that we change the manager, the director of the hospital first to see in the big picture, because if we set up the hospital in the operating theater, okay, we ask the surgeon. In the ICU, we ask the doctor in medicine. In the general ward, we ask the nurse what to set up. But don't have anyone to see in the big picture. I think it's maybe have something that link it, something that interfere each other. So for the training, I saw that some cost from the ECI. It's a technology management. I think it's a good point for the manager or the top level of the hospital to learn how can you manage the technology. Unnecessary to do by yourself, but if you have the knowledge, you can coordinate it very well. And for the user, the nurse or the doctor, I think is we need to teach them that how to use the equipment, how to take care of the environment in the properly. And the second thing that is more important, I talked to our manager Kun Chalampon. He told me that is we need to teach nurse to maintenance by themselves. I tell Dr. Kun Chalampon that it's so crazy why you put your job to a nurse. He tell me for the example, if you want to buy the car, if the car is belonging to be a woman, the car of Dr. Yamnut, and the car of Dr. Pilot is a man, which car that you want to buy? Dr. Pilot. Because if the woman, you buy the car, just only push the key and start and drive, and maybe not the correct, we don't know about the raw and how to make it suitable. I never check the water in the tank. I never check the pressure in the tank. I never done, because I believe that every 3 months I will put it in the engineer to check them by myself. But if Dr. Pilot, the man, if they belong in the car, he check by themselves, daily checking by themselves. Oh, okay, I get the idea from Kun Chalampon. So we need to teach my nurse, to teach the doctor. You choose to maintenance by yourself. Don't wait for the biomedical engineering to do it. I think it's very important for us. And in the next 2 years, we need to know that for the professional that the engineer that we do in the hospital, in the next 2 years we have the standard of the Thailand that need a certified person. The first is the clinical engineering. The clinical engineering, I think it adopted from the Japanese country. For the complexity of medical equipment, the C-arm, the laparoscopy. Clinical engineering that certified clinical engineering will handle the equipment, not by scrub nurse. And the second is healthcare engineering. Healthcare engineering is the engineer that will take care of the building, the chiller system, the lift, for the air environment in the hospital, not general engineering. The engineer that's certified. We call the healthcare engineering. And the last is biomedical engineering, the engineer that who take care to preventive maintenance or repairing the medical equipment. For Thailand, we have a graduate course. We have the graduate student that many university, the biomedical engineering. I think it's for 10 years ago. But he can use the biomedical engineering is just only a few, 100 people per year. But 10% of them work in the hospital. 90% is sales representative. So it's a really constraint is for the resource person. But I think is the biomedical engineering is we try to pull them back to the hospital, how to make them that he have a career path. If we trust, if we respect together, I think we can pull biomedical engineering to do that job in the hospital instead of sales representative. And RS, we have the training that cooperate with the ECI to train the biomedical engineering, or in some hospital, if you have not have a biomedical engineering, but you have a electrical technician, or you have the electrical engineering to train how to take care the equipment. I think it's a direction of the Thailand, direction of the RFS.
Thank you very much, and do not buy car from Dr. Yamanut. Thank you very much for your contribution, and I'm sure that the mission, one of the RFS mission is, as you mentioned, to lift up this professional competencies, lift up the standard of these professionals to promote the fasting management in healthcare sectors, right? And for the last few minutes, I'm sure that we have an international expert with us here. Not many times that we have together the 4 persons on the stage, so I would like to welcome the questions from the audience. a few questions would be nice. Any questions from the audience? ถามเป็นภาษาไทยก็ได้นะคะ
I did have a question. I thought I'd just like to share some notion of big data, which we're working on, which might be interesting to you. That big data is one of those things that Google understand and are vastly ahead of most other people in the world, but almost everybody else has no idea yet about the implications of it. I don't think. But anyhow, we have a piece of work underway that says, well, if you give me the staffing, we call them rotas, staffing rotas. It's the allocation of nursing staff on a ward, okay? So if you tell me over a period of time what grade of nurse you have on, what time they work, what their shift patterns are, what they work for the last 2 weeks, etc., so on and so on and so on and so forth, then we believe that we will be able to tell you where your high-risk exposures are. Now, in our country, Sunday is a day when many people don't work. It's a religious day. So therefore, typically, staffing levels in hospitals, believe it or not, reduce. And so if we've moved in England to shift patterns for nurses of 12 hours, 7 till 7. 7 till 7, 4 days a week, and then 5 days off, or something like that. My guess is that if I look at the data for Sunday at 4 o'clock in the afternoon, I bet you I could start to tell all sorts of things about outcome activity on that ward, and by that person, in that team. I have no idea yet, because we haven't done the work, but we believe that we'll be able to develop over a period of about 18 months a predictive ward-based, whatever you like to call it, management model that allows you to be able to recompense for areas of inadequacy, that in safety terms, in control terms, in resource allocation terms. So I'm going to save lives, I'm going to save money, and I'm going to improve the productivity of my staff. And I think within 5 years, wherever you are in the world, we will be using some kind of system like that to not only operate our wards, but in the bigger sense, to operate our hospitals. So hospital management, won't be people who have MBAs and goodness knows what else, like me, and there'll be people who understand how to use vast amounts of data that have been through artificial intelligence, have been crunched and crunched and crunched and crunched, that allow you to be predictive about how your organization will respond to a range of stimuli and factors. So that's a piece of work that we're involved with, and I think a lot of people are as well. So,
Very impressive. Yes, please.
Question. If I were to approach my CEO to ask for a budget, I think what we've been doing for the last 60 days is very good. Something he wants to do to ask for. But of course, there was what sort of levels of budget we allocated to get there. So, of course, as mentioned before, varies depending on the size of the operations. But there's some thumb rules that we can use. Some simple database states like this size should be your allocated budget for. Is there any sort of like that around?
Okay, so what's the rules of budget for facility management investment, right? So I believe that different area of practice like facility management, biomedical engineering have different number or ratio. And one of the things that we're trying to do is that the questionnaire that we provide you before we come here give a very good number of what the practice in Thailand. But for the international benchmark, if you have the numbers of ratio or benchmark to provide, would you recommend maybe from medical device, Eric, any rule of thumb for what should be the budget for the medical device management?
It's very difficult to say. Generally, I hear from many countries' engineering department, it ranges between 5 to 12%. Some of the countries are below 5%. I know, especially the South Asia country, they budget very little to manage the technology. We're not talking about replacing the technology. We're talking about managing the technology. 5 to 12% includes resources of manpower as well. So it's a very interesting thing to do. What we do in Agri Institute is that we support our clients and our customers and hospitals to look into the number of technologies that you have. Our general rule of thumb, number one thing we do, because we are evidence-based, we need to know what are the technologies you have. From there, we are able to then look at what sort of budget you will need. We're moving forward. A lot of hospitals in the West and some of the Northern Asian countries are working with us on what we call the predictive replacement program. We actually plan for the hospital to have a budget on not just maintaining your technology, but also to predict what you need to budget for the next 1 or 2 years. Anything more than 3 years is not realistic. So do not think that I can budget for 10 years. It's not going to be realistic. So there are many elements in all these programs that you can work on. But if you ask if there is a general rule of thumb, there isn't a hard and fast rule that is published or something like that. But a lot of the hospitals that I went to, that I see over my last many years, they're between 5 to 12%. So it's depending on what you do. So if you will need an evidence base, we have to work on the actual numbers by itself. Yeah.
Any things from you, Paul, about the budget?
I don't know this is an answer to the question, but when I was a chief executive, if somebody came to me and said, we'd like you in an accelerator and it's going to cost $110 million, the obvious question is, well, why? And what am I going to get out of it? And 9 times out of 10, the people who came to me, my staff, were so poorly prepared for the question that, I switched off about 3 seconds into the conversation. And I'll talk later about, creating models that allow executive people to be excited about investment. So in England, as again we'll hear later, we're pretty broke in the National Health Service. So if you come to me and say, Paul, could I have £20 to do this? I say, well, what is it going to give me? Well, it's just going to make things a little better. No, go away. If you come to me and say, could I have £20 and by the way I'm going to give you back 10, I'm going to say, let's do that. And I'm going to talk in terms of infection, the costs of infection later. When people say, oh, I can't get this equipment because they won't pay for it. Well, if MRSA costs £10,000 a case extra, and I can save 1,000 cases a year, I've already got my investment. So my only real advice is that in my country is that people need to smarten up on their ability in business analysis, in the presentation of, and I come back to this word again, we're moving away from cost, we're moving entirely into value and outcomes. Clinical outcomes and absolute value. So if you talk about, we use a concept called quality of life years, which I'm sure is a universal concept. So if I want to evaluate something, well, tell me the quality. What am I going to get back? Not as a hospital necessarily only, but as a society, as other parts of government, and so on and so forth. So that's my sense of that if I was in the other side of the table and wanting the money, I'd make sure I was presenting myself a lot smarter and a lot more informed.
Thank you very much. Yes, Mr. SK?
Okay, I think that's a very, very open question and very interesting question. And I first thought was, I concur with Paul, that when you come and ask me for money, and if I'm the boss, I'll say, what do you want the money for? First thing, what do you want it for? Because if you come in and ask for a budget and do not have something for me. Basically, as a management or the CEO, what I'm looking is that do I have return on investment, which is what Paul is looking at just now. So if I give you 10 million that you ask for, am I putting that into the drain? Or do I get something in response to improvement, that whether it's tangible or intangible? So do you have a business case for this? Do you have a case for improvement? Or maybe I just share with you, some years ago, we have this program that develop people in the companies, that in this program where they develop people, development means that it can be training, it can be a career path, it can be many other things that really enhance capabilities and quality of the people, employees within the organization. So when they embark on this program, so specifically just on this area alone, they ask for a certain budget or training. And typical budget allocated in this area is 4% of the salary, of the total salary. Okay, at that point in time, where they talk about training and skills development and things like and advancement of individual, okay, that's a typical 4% of the salary. But then, along the way come the financial crisis and things like this happen. The 4% just vaporize into the air. So there's no hard and fast rule in this area. Again, if you're looking at some organization looking at innovation and they do allocate a certain amount of budget based on the production or the revenue. Okay, so it varies. I again don't have a good answer for this. I think the basic thing is that do you have a case for this, and again, can the company or organization afford it? Yes. Thank you.
A little bit onto the two gentlemen beside me who has mentioned a lot about justifying what you want. It's a good idea to just go to your boss and ask for the money, and they rightfully say you have to justify it. Here is one of the good reasons to justify it, which so far today, I have not found any CEOs or any directors of any health authorities to say that is wrong. Everyone I meet when I talk about that, it's always correct. The answer to it is that it is always for your patient's safe and a good outcome. At the end of the day, if you justify what you do to ensure that it saves costs, ensure that your technology provides consistency for the patient, and the patient get consistent good outcome from the treatment, that is a good justification enough. We often talk about when we want to buy something, is there a return on investment? Yes, I was a chief operating officer before. I also talk about return on investment. Return on investment can be seen from and perceived from various values that we talk about, like what Paul is talking about in terms of value. If you would have less problem with a patient, just imagine example. If there is a lawsuit of a patient to your hospital or your organization today, how much do you think you will have to pay for the lawyers and the legal approach and solve this particular problem with the patient itself? Imagine that. So the amount of money can be in various forms. And let's look at then the positive side of things. If you consistently provide good output for your patients at the end of the day, there will be only more patients coming in. I will tell my mother, and my mother will tell my mother's friend, and my mother's friend will tell my other mother's friend. Just like Paul says in London, I can check which hospital I want to go to with good outputs. Right? So it only enhances that and only brings in more patients for the hospital. Some public hospital may say, I have not enough staff, don't give me more patients, I have not enough people to deal with it. But here again is about then doing what is correct. At the end of the day, wherever I go, every presentation I do, I would just want to remind everybody in the room, it is not about you, it is not about me or the hospital, it is about the patient. Without the patient in this world, which is human being, there's nothing that we need to do. We can all just go home. At the end of the day, patient safety is the number one justification, no matter what and who you talk about. So maybe that could be a very good justification for what you wanted to do, but make sure there is a good reason behind all the other justifications. But I think patient safety cannot be ignored. Right? Thank you.
Thank you very much, and thank you very much for everyone, and I think it's about time for your lunch. I would like to thank you again for our honored guest speakers, and you meet Paul again this afternoon after lunch. We will come back here. Now it's about 12:30. We will come back here as, could we have like 45-minute lunch? Yes? Thank you so much. We will come back here as 1:15 after lunch. Thank you so much. ขอบคุณนะคะ